Good morning, everyone. Today's first case is a 58 years old male. As a personal history, has hypertension and he's a former smoker. The patient went to the emergency room due to the typical chest pain lasting 30 minutes. In the analysis, an elevation of troponin was observed. The electrocardiogram and echocardiogram were normal. A first catheterization was performed in which the right coronary artery presents a proximal occlusion. A pilot 50 guide wire was advanced, the artery was predilated, and a stent was implanted with good result. Regarding the left system, he presents a severe lesion in the LED ostium with doubtful involvement of the left main coronary artery. For this reason, the patient will undergo left main and LED angioplasty assessed to the left main by IVUS.
The angios of today are these. This is the caudal view. As you can see, there is a narrowing from the distal left main towards the LAD. The circ looks healthy, and the LAD is diffusely diseased. Probably difficult point is to decide where is the distal landing zone here. And Borja, okay, you are going to see the pullback from the LAD. You are seeing a diffusely diseased vessel. The distal zone is quite distal to the second diagonal, is 2.5. There are some healthy segments, but it's difficult to choose the perfect landing zone. We have been discussing this issue before the connection. Some calcified plaques, nearly 180 degrees of the circumference. This is the diagonal, the second diagonal, rising. This is the proximal mid-LAD. Proximal LAD is 3.25, 3.5. This is the ostial LAD, and you're going to see the circ. This is the circ with the wire, and this is the left main. Okay, this is the proximal LAD, 3 point something, 3.5 probably. The next one, Borja. Mid-LAD, and distal to this point probably is 2.5, all the vessel. So we are going to predilate the ostium of the LAD and the left main. Which balloon?
Or cutting.
Or cutting, yeah. The calcified plaque is not too heavy. Can you put the ostial LAD, Borja? There, okay. The plaque of the ostium of the LAD is not heavily calcified. Probably, I am going to describe the image now. Yeah, it's a mixed plaque, probably, there, perfect. Not heavily calcified. We know from several trials that cutting or scoring balloons do not work well in heavily calcified lesions. Yeah. But probably in fibrotic one or moderate calcified lesions is a good option.
Overall in ostial lesions.
In ostial lesions, but aorto-ostial probably has more elastic fibers. I don't know if ostial LAD lesions. So we are searching for some cutting balloons or NC balloons, and we will decide 3.5 to 10. Okay, we are using a Wolverine cutting balloon just to dilate the left main to the ostium of the LAD. So we are advancing the cutting balloon.
Yeah.
Okay, we are almost there. Test, please. We are there. Probably a little bit more distal.
Yeah.
Okay. There. Which atmosphere do you want? 10. You know that the nominal is 6 and the blood rated burst is 12. I'm going to 10. There are some debate about the atmospheres you need to get with the cutting balloon. To be honest, we use them probably as similar way that a conventional NC balloon, but we are being more conservative today with 10. Higher or 10 is okay?
10 is okay.
10 is okay. The expansion is quite good.
It's enough because the plaque is
modified, no?
Yes.
Okay.
Dissection, no? So
a little bit dissected, yeah. I think the cutting balloon did its job. I am concerned about the plaque distal to the diagonal, but we can do, as Guillermo said, we can fix the proximal part with a stent and then recheck everything, no?
Yes.
Okay, we are advancing the synergy stent. Okay, this is the stent. Let's see.
Okay, before the first diagonal.
I think
the spider is
the spider is better?
I think.
The proximal landing is okay, no? So the problem is the distal landing zone before the diagonal, no? A little bit more forward.
Vamos a hacer un cine y
Okay.
seguimos ahí, ¿vale?
Okay.
I think it's a good position, no?
Okay, let's go.
Yes.
I'm going to nominal, that is 11. Because it's a little bit, this is the distal plaque part, 11. With expansion, okay, down. Blood pressure is okay. The ST a little bit modified, but just slightly, okay.
Now probably the lesion distal to the first diagonal is worse than before.
No, there was plaque there. Okay, let's do cine after nitro. Okay. Probably the plaque is similar than before, but you see the fixed proximal part. I think I told before, probably we need to fix it. We can do IVUS if you want,
okay.
or
I think we can do the pot after IVUS, okay, and we decide about.
Okay, and we can check the pot result and save one step. Or put the B5, Borja.
I think it's 4.
Can we have a NC balloon 4/8? No, the other important part when you do a bifurcation like here is to put enough length in the proximal vessel to do the proper pot. Okay, that is at least the length of your shorter balloon. We are using a 4/8 balloon, and we have enough space there to do the pot. And the proximal lumen of the left main with IVUS was 3.9, the lumen. So we are using a 4 balloon, 3.86.
I think we inflate in the osteon low pressure, okay?
It was a little bit under expanded
Now the real pot.
Okay, we are there. Okay. Down. Okay.
Vale, toquecito.
No hay nada. Okay, I think it's okay. Let's check the circ. And I think if the circ is okay, we can retrieve the wire from the circ and use it to protect the diagonal. One controversial issue is if you need to do kissing balloon when you do a provisional stent technique in bifurcations, especially in the left main. We are not doing kissing if we see in general that the side branch, in this case the circ, is okay. And we think that after the pot, if the angiographic result is okay and the IVUS in the, I think it's okay. Let's do the other caudal projection, the right, to see the osteon of the circ.
Yeah.
There is also a funny small intermediate branch that is still alive after the stent.
Probably.
And we can focus on we can do IVUS. That's our plan. IVUS, please. Check it, and we can interrogate also the result of the stent in the left main proximal LAD, and even the distal landing of the stent, and probably the need to treat the distal, the plaque near the diagonal.
Okay. Ese es nuestro stent ahora.
This is the stent.
The position is good, no?
The position is quite good in the distal part. The expansion is also very, very good. This is the circ. The osteon of the circ is open.
Yeah.
And the proximal part is well opposed.
Yes.
Perfect.
The pot is.
Okay, stop. You can see now the IVUS, and Guillermo is going to analyze it outside. You can see now the pullback. This is the mid LAD. Distal. This is the diagonal.
Yes, this is the first diagonal.
This is the diagonal. So you can see the plaque there. So 3.2.
Yeah.
Probably is another reason to treat it, no?
Yeah. Probably we need protect the diagonal
Yeah.
and implant stent.
And can you measure a healthy landing zone distal to this part? Probably between.
That's the problem. Which is the
Yeah, there.
the best
It's
part?
2.5 probably.
Probably more or less here.
Yeah.
I think 2.75.
2.75 could work well. Okay. Okay, so probably we need to remove the wire from the circ to introduce it in the diagonal. It's not very calcified, this part, but probably we need to predilate a little bit, no, Guillermo?
No, I
Or
think
direct extend.
no,
Direct extend.
Yes, no problem.
At 2.75, a synergy 2.75, and probably with the putting together the IVUS and the angio, the practical co-registry, probably a short stent could be enough. What do you think? In the IVUS you have 15. Probably is that,
Yes.
no? For near 15.
More or less, yes.
Okay, we can put the screens again than before. What? You're there. Okay, perfect.
The advantage of the Sion Blue is maintain the curve.
Okay,
Can
I think just is enough.
more or less, yeah.
Okay, the thing, Guillermo, is 3 by 16
Yeah.
or 2.7 by 20. Let's put the cranial view. That probably is the best one to decide. Wait, sorry. I would go for the 2.75 20 or
I think yes. It's
2.75 20.
yes. No problem with this. Yes. I think the before the dust is the septal, no? The
Yeah.
three septal more or
Yeah.
less. Before
Yeah, it's difficult to find in the angio and also in the IVUS the best position between the both diagonals because all the vessel is diseased. I think we can go overlap in the stents and then post-dilating the proximal part of this one. And let's see all the images. Suelto.
Thank you.
Okay, let's go with the stent. As Guillermo said, we haven't seen any severely calcified plaque. We are going with a direct stent. Okay, let's see with the wire. Escopia, por favor, que te centre un poco esta, a ver si se ve mejor. A ver, escopia. ¿Por qué no se pone más grande? Let's see if we can see it. Okay, let's do a stem boost.
Oof.
This is the point. I don't know if you are seeing the stem boost, probably not, but the stem is a very important thing in every stem, and also in this one. The proximal radiopaque marker is not the proximal edge of the stem.
Now I finish is good.
Guillermo has retrieved a little bit the stem, and we are doing another stem boost. I think you are in the perfect position now. It's perfect
Yes,
now. Okay. Let's show it with the angio. So I'm going to do cine o test?
Test. Yo creo que es mejor ya no moverlo. Ahí está bien.
We are there. Okay, let's go.
Yes. 12, please, because 12 is
Nominal is 11,
Nominal
12, more or less, yeah? 6, 12. The expansion is quite good, probably a little bit underexpanded
no, but,
at one point.
okay, but
down.
I'm going back with the balloon and we can
Overdilate a little bit inside the stent. Okay, there. Okay?
Okay.
Let's go there.
18.
18. 18. Okay. Expansion is quite good.
Okay.
Go down. Okay. So we need to do a pot.
Test, please.
Test. No, I think the distal edge is perfect because the disease is there, but
Probably the diagonal is the flu is good, but probably is in jail, no?
and we can do the pot firstly and then recross.
Yep.
Let's treat the which balloon
or
nothing.
Is the fluid is good?
Okay, we can decide. So for the pot, 325, 3.
Yeah, 3.
NC balloon 3 by 8, 12. Perfect. 3 by 8. So this is another debate. This is we can look at it after the pot in another projection to see the ostium of the diagonal. And this is another question. If you have a good flow but a pinching in the ostium, we will need to decide.
The LED is perfect now.
Let's check the diagonal. Okay. I think we can do a couple of projections to show the final result from now, and then cut the connection and finish the case with the IVUS and thinking about the diagonal. Okay. The flow is perfect in the diagonal. Let's do another projection probably. So this is the point.
Yeah,
what do you think?
But the flow is perfect. No? I think we can leave without treat the diagonal, no? Because the flow is very good.
You decide. Probably another option is to try to recross with a wire and then do another without the jailed wire, or leave it like that. The LED is almost perfect. We can do another IVUS if you want to check the result. Okay, we have to retrieve the diagonal. Yeah.
I think the result is
yes, also because the diagonal is quite diseased. The flow is good. The image is similar than before, and if you dilate, probably you're going to dissect. And you are finishing the case with 2 stents, that probably is worse for the patient. Okay, I think we are done. Or you can do. You want to do another?
Beer.
We need to do another IVUS at the end.
It's mandatory the deluxe IVUS for the IVUS chip.
Yeah, we are doing another IVUS just to finish the case. We have 3 minutes probably just to do the IVUS in the LED and finish the case. Okay, I'm going to start the pullback now. We are distal to the second stent. The position is perfect, the expansion as well. Probably could be a more proximal side of slight under expansion, but the areas are perfect till now. This is the one branch. The stent looks quite good.
It's a circle, no?
Yeah, no, it's perfect.
That's the diagonal?
This is the proximal. This is the circle.
Yes.
And this is the first stent. I think the result is quite good. Let's see okay, this is the left main. Okay. So we are finished. Thank you for being with us. We do apologize for the technical problem.